be a mechanical or nociceptive problem. That's the answer. More localized pain is more likely to be nociceptive. Conversely, widespread pain is more likely to be nociplastic. Responsive to simple analgesia, NSAIDs, absence of constant unremitting pain, more likely to be nociceptive. Constant severe pain, more likely to be nociplastic. Psychosocial, central sensitization, and so on. So this is just a really nice list to differentiate between mechanical or nociceptive and neuropathic and nociplastic. I'll get on to nociplastic in a second. I've just seen there's a whole lot more questions. So I might just quickly go back to the Q&A. So one person said, we don't get a lot of chronic pain. There's no insurance coverage. They come in with recurrent pain. Would you do the full assessment with someone with acute recurrent pain? Well, as I said, so the short answer is you wouldn't. Such a complete assessment is not necessary in every case of acute pain. One thing about acute pain is that a lot of it does tend to get better anyway. It certainly gets better if you treat the inflammation. But yeah, you want to drill down with acute pain using your hypotheses to what the most likely source of symptoms, what the most likely problem is. So yes, you wouldn't do as comprehensive assessment, but you need to, if they've got leg pain, you need to do a neurological examination. If they've got recurrent pain, you might settle the inflammation and then bring them back 2 days later and assess their motor control, because one of the key things with recurrent pain is preventing the next recurrence. And motor control, there's some data around that shows that if you optimize the motor control, build it up into function, that's going to prevent their recurrent pain from coming back again. Is another example of what you would do with treating recurrent pain versus chronic pain. So yeah, in an acute situation, you've got to use your reasoning to a greater degree. But, you know, again, with me, my go-to sort of recipe, and I don't like recipes, but is settle inflammation. Once inflammation's settled, you might want to do some of your passive techniques to ease the pain a little bit further. And then I would get them onto a motor control approach to try and prevent the recurrence. And you can do that in probably 4 to 6 sessions if they're not having insurance coverage. So hopefully that's a little bit helpful. Another question is postural deviation through weak overactive muscles, or does postural adaptation lead to musculature issues? So I'm not quite 100% sure what that question means, but certainly, as I alluded to, with your long lordosis, that's more likely to be due to overactive erector spinae and underactive multifidus. You can obviously get, if someone's had a postural deviation for a long period of time, they can get adaptive shortening of the ligaments and other structures, and you may need to do some mobilizing or stretching types of techniques. But a lot of postures are fairly readily reversible, and so are more due to muscle activation issues. Another person has picked the hip drop and the glute medius, so that's excellent. Just going through the questions. There are algorithms for the management, like the treatment-based classification. Do you suggest any algorithm for the assessment of low back pain? Look, we're doing some collaboration with Julie Fritz, who developed with Delido the treatment-based classification. Our personal approach is that that's probably a little bit too simplistic in nature, the treatment-based classification. It's an approach. It's got some evidence to support it. Again, the STOPS papers that I'll refer you to at the end of the presentation do have an algorithmic approach, but it's quite a lot more complicated than the treatment-based classification. So it depends on your population and what your preference is. How can I objectively check the multifidus activation? Again, that's in the STOPS papers that I'll refer to at the end of the session. So it's too complicated to go through that, particularly virtually. But there's quite a lot of detail in the STOPS papers about checking multifidus activation. Okay, so keep the questions coming. Sorry, I lost track of those with the with the presentation. All right, so just have a look through these features. This is obviously nasoplastic pain. So nasoplastic pain, as I said, is potentially due to central sensitization, psychosocial factors, and so on. And these are the sorts of inconsistent presentations that you're seeing: widespread non-anatomical distribution, failed treatment, psychosocial factors, more constant, more severe night pain, hyperalgesia and allodynia are also, secondary hyperalgesia are also very, very important. So this is your nasoplastic. Just be aware, if you are seeing recurrent or acute low back pain predominantly, there are quite a few patients who do have relevant psychosocial factors. So I would be giving a patient, particularly if they're not getting better with acute low back pain after a couple of sessions, and a rebro or a start back, just to test whether there's relevant psychosocial factors or not. So there's sometimes an assumption made that nasoplastic pain is all with chronic pain, and with acute pain, it's all nociceptive and neuropathic. It's not always the case. There's been another question here about crossover syndrome and transversus abdominis tone with crossover. Look, my reading of what would Yander call the proximal cross, which is tight iliopsoas and underactive abdominis, and you get this increased anterior pelvic tilt and an increased lumbar lordosis, tight hamstrings, those sorts of things. There was a bit of data around that when Yander first sort of popularised that opinion. It hasn't been that strongly validated, but the short answer is yes, I would agree that if you've got poor transversus abdominis tone and control, that you're more likely to have that sort of floppy, increased anterior pelvic tilt and probably some tight iliopsoas, and that's that proximal cross or lower crossover syndrome. So yeah, I would tend to agree with that. Okay, so we've got some examples here, starting to move into the time limit. Just some quizzes. I'm going to go through these reasonably quickly. So you've got some clinical features here, and then you've got some treatment approaches. Have a read of that and pick an answer. So this is an example, if you're looking at those features of pain types, of a likely nasoplastic pain type: constant, severe, diffuse, bilateral leg pain, failed treatments, the surgeon wants to do a fusion even though there's no nerve compression. And so you would give this patient pain education and lifestyle advice. What about this one? All right, just to be clear, pain education is around educating the patient around the nature of chronic pain, the nature of central sensitization, and then engaging them in a reactivation program, which I'll get to later. So this person's slightly different. This one was more like a nasoplastic pain problem due to central sensitization. This one's more like a nasoplastic pain problem due to psychosocial factors and low mood. The question here is, what's the best way to address that low mood, the severe depression? You could then send them to a psychologist, but there's pretty good evidence here that the reason why they're depressed is because of their work situation. Work covers the compensation scheme. So on that basis, you could argue that doing a worksite assessment, I appreciate this isn't relevant probably to India, but just to illustrate your point, doing a worksite assessment, try and sort out these work issues may well help their depression. And if it doesn't, you might then send them to the psychologist. Okay, what about this one? So catastrophizing is when they're overblowing everything about their pain problem. I'm never going to get better. My pain's so severe I can't do anything around the house. I can't exercise. These are all examples of catastrophic thinking. What are you going to do with this patient? You're going to give them some relaxation. You're going to get them going on a graded activity and exercise program to try and desensitize them, work through their fear avoidance beliefs down here. Well, probably the first thing you need to do, and this gets into behaviour change and cognitive behavioural principles, which is, again, too complicated for today's session, but you need to provide them some sort of information on the fact that they can have pain and it doesn't mean that it's causing them harm. So it's some sort of education first, that exercise is not going to make you worse, it's actually going to help you. It's not going to cause harm, even if when you exercise, it's causing a little bit of pain. And then once you've done that education, you could potentially send them to a psychologist. Sorry, that's not actually... Okay. I'm going to move on. All right, this is a bit more of a mechanical one for you. Have a look at that. Okay, so these are deliberately a little bit tricky. They responded to McKenzie initially, and this is quite a common phenomenon, where they respond to a McKenzie-based approach initially, but then their response plateaus and they just end up getting chronic low back pain. They're struggling to get back to work. Maybe you need to get them to do lifting practice and work conditioning to get them back to work. But this goes to that recurrence issue. What is going to happen if you put this patient back into, or put them into lifting practice and work conditioning? It's likely that they'll flare up. What's going to stop them from flaring up? Addressing their motor control. So get their motor control going in low-level postures and identified impairments. And once they've got that going, then you get them going on their lifting practice and their work conditioning. Rashid's doing very well. Good work, Rashid. Okay, so there's just a couple of examples of how you can individualise treatment based on your assessment findings. And again, if you're not identifying those assessment features, then you're not going to be able to provide your individualised treatment. So look, just to finish off, we've been going for an hour and 20 minutes. I'm going to compare some of the different individualised physiotherapy approaches. I'm not actually looking at the treatment-based classification, which we've had a few questions on. I think it's fair to say that Julie Fritz and Delito first published that back in the 90s, and it's probably something, which doesn't mean it's wrong, but it's probably something that hasn't been researched as much in the last sort of 10 to 15 years. And other individualised physiotherapy approaches have become more prominent, which again is not to say there is some data to support the treatment-based classification, but not a lot of really strong RCT data around it. Okay, so I'm going to take you through 3 individualised physiotherapy approaches, one of which is STOPS. So the first one is the start back classification. So this is actually the wrong screen grab, sorry about that. But Jonathan Hill published an RCT in 2011 on the start back treatment. So basically, the Start Back tool is a risk stratification tool. It's a 7-point questionnaire, quite similar to the Arebro, but very simple. It's just basically, are you depressed? Yes or no. Do you have fear avoidance beliefs? Yes or no. And it was designed to be used by GPs. And what it does is stratify people into either low risk, medium risk, or high risk. The low risk group basically get advice, so guideline-based advice. The medium risk group gets 6 sessions of physiotherapy, and the high risk group gets 6 sessions of physiotherapy, but from very highly trained physiotherapists. So it's a way of targeting and individualising your treatment, but it's a fairly crude method of individualising your treatment, and it doesn't encompass the pain type or motor control or any of the things that we've really talked about. Again, it was devised for use by GPs. It has been, I'll get to the literature later on that. Cognitive functional therapy is, but yes, one thing about Start Back, it's being rolled out across the whole of the Northern Hemisphere. So Start Back is being implemented very widely across Western countries in the Northern Hemisphere. Cognitive functional therapy was introduced by Peter O'Sullivan. They did a trial. Carlton Fursum did an RCT in 2013, I think it was. And this is a review article, so if you're interested in cognitive functional therapy, this physical therapy article published in 2018 is a nice summary. Cognitive functional therapy is essentially a multimodal biopsychosocial based approach to treating and rehabilitating people with back pain. And essentially what you do, it's a little bit aligned with guideline based. So you assess across all of the features that we've talked about. You give them a screening tool, Start Back or the Arebro. There's that sort of Start Backy feel about it. So if they're low risk, you give them a couple of sessions of cognitive functional therapy. And if they're high risk, you give them a more intensive cognitive functional therapy approach, which includes education, graded exposure to activities that cause pain, lifestyle changes, psychology as necessary, pain management as necessary, and booster sessions. So this is basically Peter O'Sullivan's approach to back pain. You either get a little bit of cognitive functional therapy or a lot of cognitive functional therapy based on your risk. So a little bit similar to Start Back, but this treatment program is actually quite comprehensive. And then this is the third type of individualised physiotherapy program. Sorry, just there's a question that's come through. Antagonistic supervisor is just there's conflict between the supervisor and the patient. So it's some workplace conflict. So this is the third individualised physiotherapy approach. So we published our RCT in 2016. This was the online version. And I'm going to spend some time talking about this. It's the STOPS approach. We think it's the best way of individualising physio, but you can make up your own mind. This is a very busy slide that summarises what the STOPS approach is. So similar to Start Back and also cognitive functional therapy, we assess for pathoanatomical, physical, psychological, social factors, and we use a screening tool. And similar to Start Back and cognitive functional therapy, we identify all of these contributing factors that might be relevant. There might be work issues, there might be fear avoidance issues, sleep issues, poor coping, and we individually treat all of those different things. So for fear avoidance, you can give them relaxation and graded exposure. For sleep problems, you can give them sleep hygiene, you can do some mindfulness, some relaxation. If they're struggling to cope with situations at home, doing the housework, you can give them problem-solving skills to help them cope. But the key difference between the STOPS approach and cognitive functional therapy and Start Back is that we only, for people with non-specific low back pain and a poor prognosis, that is with a high risk of poor prognosis, we would give them all of these things and we would give them a pain contingent graded activity and exercise program along the lines of a cognitive functional therapy approach. But there's these other types of low back pain that we would treat very differently. So if you've got, and remember the STOPS approach was developed for people with subacute low back pain or recurrent low back pain. So if you've got someone who's likely to have discogenic pain and you put them in a graded activity and exercise program and do all this green stuff, they're less likely to get better. They'll respond much more readily if you give them a specific approach that's targeting the disc. Similar with Z joint or facet joint dysfunction, specific manual therapy, they're going to respond better. There's other types of disc problems, particularly disc herniation with radiculopathy, leg pain and nerve dysfunction. If you put someone with radiculopathy into a time-contingent graded activity and exercise program, they'll get worse. So they need a pain-contingent graded activity and exercise program, and I'll explain to you what that means in a second. In addition, all of these orange categories need specific muscle activation and management of inflammation, which we've talked about before. So there's a lot of similarities between STOPS and start back and cognitive functional therapy, which you can see in green, but there's some very key differences, which you can see in orange. So just a little bit about the STOPS trial. What we did, we got 300 patients, we randomised them into specific physio, the STOPS treatment, or guideline-based advice. We had really good follow-up, very low dropout from the trial, so it was a high-quality trial, methodologically speaking. And these are the results. And look, really the key thing about the results is that both groups got better. So you can see the advice in orange. So we followed them up at 2 years. The advice group, they all started off at fairly severe back pain, around 5.5 out of 10. They both got better, going down to sort of 2 to 3 out of 10. But the STOPS group got better a lot more quickly. So it took 5 weeks having the STOPS treatment to get to the same pain level that the advice took 1 year to get to. So if you have advice, you get better, but it takes a year to get better. Whereas if you have STOPS, it takes 5 weeks to get better. So we would argue that's a pretty significant difference. Oops. And look, this situation with the leg pain is the same. The leg pain gets better much more quickly, and disability also gets better much more quickly, and stays better even at 2 years. So that's basically the results of the STOPS trial. I'm not going to sort of go too much detail into it. Again, I'll reference the paper at the end. But more than just the effectiveness on pain and function, STOPS was highly cost effective. So when you look at the cost effectiveness, including the treatment costs, each case saved $3,000 compared to the advice group. So it was $3,000 cheaper when you look at cost effectiveness analysis. And in Australia, the way you evaluate cost effectiveness is by this thing called a QALY, which you probably don't need to worry too much about what a QALY is, but it's a quality adjusted life year. But in Australia, the Australian government will pay for a QALY of anything that's less than $50,000. And you can see the QALY for the STOPS treatment was $650. So again, the STOPS trials was highly cost effective, more cost effective than epidurals, more cost effective than cognitive behavioural therapy, more cost effective than non-steroidal anti-inflammatory drugs for osteoarthritis. So really very good cost effectiveness data. We've since finished another pilot RCT on 40 patients, and this is for more, so remember the STOPS trial was in subacute low back pain. This is in more complex chronic low back pain. We use some of these additional questionnaires. We randomised them based on pain type. So remember the nociplastic, neuropathic, nociceptive. We had a clinical computer-based decision-making algorithm. So in terms of the decision-making, someone asked about the treatment-based classification. We've actually developed a computer decision-making algorithm to help people negotiate their way through this assessment process. And we tested it. I won't go through the statistics, but basically these are the effect sizes. Remember that effect size of over 0.5 is moderate, and effect size of over 8.8 is large. And going back to the guideline conversation, very few treatments demonstrate anything more than small effects. And you can see here, this is the best data that came out of this trial. Remember, it was just a low sample size trial. So a pilot study was on the neuropathic pain. So people with radiculopathy and due to disc herniation. And what we found was very large effects, up to 2 at 12 months, and 0.9, that's for leg pain. So highly effective for leg pain. Effect size of 0.9 on back pain, and effect size of 0.5, still moderate for oswestry. And that was at 12 months follow-up. So there's good data coming out for more chronic cases of low back pain, particularly neuropathic pain, that stops when it's done with this decision-making algorithm is really effective. How are we going for time? We've got half an hour left. Look, I might skip through this. This is sort of fairly dry about clinical importance. If you're interested in, really determining whether one treatment, the effects demonstrated in RCTs are clinically important or not, you can have a look through this afterwards. But the main thing is that when you compare Startback really only had small effects on disability, didn't have any effect on pain, and there was some cost effectiveness based on reducing unnecessary treatment. So basically Startback helped by the majority of the people going and getting advice, and advice is cheaper than physiotherapy. So that's how Startback works, which Jonathan Hill admits. I've spoken to him about it. As I said, Startback's been replicated in a number of other jurisdictions, and the results seem to be pretty underwhelming. So there's no replication of the Startback findings in other RCTs. Cognitive functional therapy. So there's been 2 trials on cognitive functional therapy, one by Vibe in 2011 and another one recently published by Mary O'Keefe. The really interesting thing about cognitive functional therapy is the dropout rates from treatment. So 30 to 40% of patients drop out from cognitive functional therapy. And we would argue the reason for that is because if you've got discogenic pain or if you've got Z joint pain and you try and get pushed through an exercise program, it's going to make you worse and you're not going to continue. So really interesting that such high dropout rates on both of these studies. The O'Keefe study showed only small effects on disability, and there was a planned cost effectiveness analysis, but that wasn't actually completed or published, so we don't know what happened with the cost effectiveness. Probably unlikely to be cost effective. And when you compare, this is on back pain, so you can see blue is STOPS, yellow is Startback, and green is the O'Keefe cognitive functional therapy trial. This is what happened for the STOPS trial, for the STOPS treatment. This is what happened for advice. So again, they both got better, but the STOPS got more better and better more quickly. This is Startback, the treatment group. They got better, sort of fairly similar. But when you look at the comparison group on back pain actually got more better than the Startback treatment, which was surprising when I did this graph. And then when you look at the cognitive functional therapy group, they got better, the cognitive functional therapy group, but not as better as the other trials. And again, not much difference with the control treatment. So you can see that really STOPS seems to be the most effective treatment. I might skip through this slide. This is about clinical importance again. So you can have a look through that at your leisure. But we would argue that the results from the STOPS trials are clinically important, which is really important when you're evaluating treatments. This is just a slide just to explain to you how these 3 individualized treatment approaches will work applied to the same patient. So just have a read through this. Actually, I'll take you through it. 6-week duration, central low back pain due to a manual handling injury. Walking eases their pain. They've got a lower rebro. That's the long form of rebro. They're worth for sitting, bending, lifting, and there's no significant psychosocial factors. So this is your classic discogenic type pain under the STOPS approach. There's no response to manual therapy, generic exercise and advice to remain active. So if this patient was treated with start back, they'd be classified as low risk and they'd be given advice. If they were cognitive functional therapy, they'd be classified as low complexity, low disability, and they'd be given 3 sessions of advice. Whereas with STOPS, they'd be classified as reducible discogenic pain. They'd be given the McKenzie approach, specific muscle activation, pain contingent graded activity and exercise for 10 sessions. So just thinking about that patient as clinicians, which treatment's likely to get the best compliance from the patient and the best results? It's fairly clear to us that the STOPS treatment is best. So it's just one case study. Okay, I'm just going to finish off quickly because I want to leave some time for question and answers on applying the STOPS approach. Rashid's just asked the question, will pain education increase catastrophic reactions, especially in people who are literate? That's a really interesting question, Rashid. I think if you look at pain education, if you look at the NOI, which is Laura Mosley and David Butler's website, who really champion pain education, I think if you've got, and a lot of the patients that I see are working class patients, they're not particularly literate, and you try and explain to them this notion of nosoplastic pain and central sensitization, and they really just don't want to know anything about it at all. So they find it very, very threatening. So I do think it's feasible that ironically pain education increases catastrophic thoughts when it's actually supposed to reduce catastrophic thinking. So yeah, look, we use pain education a lot with our nosoplastic pain patients, but it has to be delivered very skillfully and carefully to avoid the patient just thinking, the physio thinks that is telling me the pain's all coming from my head, which is the classic sort of reaction that you get. Okay, so these are the 5 subgroups in the STOPS trial: disc herniation with radiculopathy, discogenic pain that responds to McKenzie, Z joint pain, discogenic pain that doesn't respond to McKenzie, and multifactorial persistent pain, which is essentially your nosoplastic pain. These are the features of reducible discogenic pain. The pain is hypothesised as coming from an annular fissure, which you can see here. They've got these features of discogenic pain that I've talked about a couple of times, and they respond to your McKenzie mechanical loading strategies. And we give them directional preference management. I've got some detail. Again, the references will show you what that is. But it's basically education, extension exercises, sometimes with a lateral shift, tape, posture, lifting advice. Z joint pain. There's pain that's hypothesised as coming from the lumbar Z joint or facet joint. They've got pain reproduced on extension and ipsilateral lateral flexion. They respond to a mini treatment of unilateral techniques, which is what Snoopy's doing, positive response. And they're provided with specific manual therapy, remembering both these groups go on to have motor control once their pain is reduced. And these are some of the unilateral techniques that we do, progressing into combined movements using Maitland-based clinical reasoning. So this is obviously an accessory movement. This is a physiological movement. Disc herniation with radiculopathy. So you can see the nucleus is bulging out further, causing compression or irritation of the spinal nerve root, causing radiculopathy or neuropathic pain. We diagnose it by radiology as well as positive neurological findings, including neurodynamic findings. And we also include non-reducible discogenic pain. So this is something that you're probably not familiar with. It's pain coming from an annular fissure that doesn't actually respond to mechanical loading strategies. So they've got these discogenic features, but they don't respond to mechanical loading strategies. And for both these groups, we give them pain contingent graded activity. So what that means is starting off with some motor control exercises, progressing into functional activity. We control the inflammation with NSAIDs, tape, lifting education, but it's all around getting motor control to support and protect the disc. And it's pain contingent. So what that means is you progress your exercise program based on their pain response. If the exercise is making their pain worse, we respect that. We don't push into that. Pain contingent graded activity exercise is viewed by quite a lot of people as being counterproductive and unhelpful in the world today. So what we're doing is quite sort of radical, really. Multifactorial persistent pain. So they don't belong to one of those pathoanatomical subgroups, and they've got a high Arebro score. This is Arebro Castle, where Arebro was made. So these people get a pain contingent graded activity and exercise program. So similarly progressing through functional exercises, but it's done in a time, sorry, that's a typo. That should be time contingent. It's time contingent. So you're trying to break this connection between progressing their exercises and pain. So they can exercise in pain. It's safe to move. It's safe to push into your pain a little bit. And associated with that, you need pain education, which is what this is. As I said, all the groups except for the multifactorial persistent pain group get motor control. So we're heading towards the end of the presentation. If you go to our website, so stops.physio, so if you just type in stops.physio and then go to our research, you can see the actual trial. So that you can see all of our research. There's about 30 papers. They're all full text, so you can read the whole paper. But these ones, part 1, part 2, are the treatment protocol papers. So this is about, I know it's about 5,000 words that describes the manual therapy approach for Z joint dysfunction. Part 2 describes the Mackenzie approach for discogenic pain. Part 3 describes the pain contingent rehab program, including the muscle activation, including multifidus. And part 4 explains treatment for nociplastic pain, the multifactorial persistent pain group, including the pain explanation and including concepts of time contingent rehab. And we also do have online modules, learning modules, which I think some of you have already done, which are available as well and take you through in even greater detail. So that's all I've got. I've finished 20 minutes early. I'm happy to take any questions, tease things out in a lot more detail. One thing I'd encourage you to do is when and if COVID settles down, we're sort of seeing a bit of a COVID mess down here in Melbourne. We're in stage 4 lockdown and we've got another 7 weeks of it. We've been in it for 6 weeks already. The cases are dropping, but it's been very slow. But if we can eventually travel, it's lovely to come over to Australia. And one of the lovely things about Australia is the bird life that you can see, all the different birds in outback Australia. And birds are really individuals. And so in finishing, I'd encourage you to treat your patients like individuals and don't exclude pathoanatomy, because a lot of people in the world today are telling us to forget about pathoanatomy, just go down a risk stratification approach. I'd encourage you not to do that and provide individualised care. This is in Kakadu. So thanks for coming, thanks for listening, and open to the question and answer. Rashid, I don't know whether you want to come in and say anything.
Oh. We'll wait for any questions.
Pardon?
We'll wait for questions.
Okay. I'm just looking at, there was a question in here around frequency of treatment. It seems as though there is a bit of an access issue in India in terms of how much treatment you can actually provide in terms of the patient's financial capabilities. I really think the whole concept of individualized treatment is really relevant when you've only got a small number of sessions to work with, because quicker you get to the nature of the problem, the more effective your treatment's going to be. So although sometimes the assessment can take a little bit longer, you will identify the cause of the problem, and your treatment's going to be more effective. So if you've got reducible discogenic pain, you identify that, get them going on some mechanical loading strategies, and that's working. I would ideally see them 2 or 3 days later to evaluate that you've got that diagnosis right. But if you do want to see them, a week later, and then start them on a motor control program and really encourage the patients that, yes, you've got your acute episode of low back pain, but you've had 3 or 4 episodes over the last 2 years. Let's try and work at this recurrence issue. Let's build up the strength of these muscles and build up your overall strength, fitness and capacity, and prevent the recurrences from happening. And most patients are prepared to pay a little bit more and have a few more sessions to do that.
Hello, sir.
Yes.
I just had a question. Right now, we have some algorithms to follow the treatment-based guidelines. It's more of treatment specific. Do you suggest any procedure or any particular step to follow when I'm going to do an assessment, and so that I don't miss something which is very crucial?
Look, I think what I presented here. So hopefully you can still see my screen.
Yeah, we can see.
Yeah. I do think that all of these features are relevant. Your risk screening questionnaire, you can give them. One thing that I do, or used to do when I was seeing a lot of acute low back pain, is that I would give every patient a body chart to fill in. I'd actually use the pain drawing, Ransford's old pain drawing. I'd get them to fill that in. I'd get them to fill out the Arebro, the 1-page short form Arebro, and I'd get them to fill out the Oswestry. And this is even with my acute pain patients. So straight away, you come in and you've got the body chart sitting there done by the patient. So that's going to tell you a lot of information that'll allow you to streamline your assessment. So if they've got no leg pain, then you don't need to worry about neurological examination. You don't need to worry about provocative neurodynamic testing. So that cleans that up. To be honest, I don't do PIVMs very often. I would always do PAVMs. Day one, I wouldn't be doing motor control assessment because it's complicated. It takes a bit of time, and someone with acute low back pain, you're not going to be doing motor control. It's pretty mandatory to do observation and active movement testing. The patient's perspective, the way that I explained it, an acute or recurrent case of low back pain, you're probably not going to go into that in as much detail. So you're really looking at basically going through these things, and then these things, and then do your PAVMs. I'm not sure about the situation in India regarding red flags, but you obviously need to make sure that you're not missing any serious pathology. But, the prevalence of serious pathology identified by red flags in primary care is very, very low. It's like 1% or something. But if you miss someone with an abdominal aortic aneurysm, that's obviously not going to be very good. Or if you miss someone with radiculopathy, or if you miss someone with cord or cauda equina, that's obviously a problem. So you need to be aware of your red flags in your special questions. But, I can, on a simple acute low back pain patient, complete this and this in 20 minutes easily, and that leaves 10 minutes for treatment. And then if they're coming back again and they're recurrent, then I'd go and look at the motor control. We've already covered the questionnaires. and probably get the patient's perspective about recurrence and what they want to do about their recurrence is how I would manage that. Does that sort of, it's not an algorithm, like it's not a sort of A plus B equals C. The algorithms come out in these papers. So again, if you go into, I won't do it, but there's a whole lot of algorithms, like flowchart-based algorithms in those papers that I referred to, that guide you through the clinical decision-making, but it's too complicated to go through here. I suppose we've got a bit of time. So what other questions have we got? Oh, there was a question. So does STOP show changes in structure like disc, joint inflammation, objective outcomes supporting STOPs? So you may want to clarify, or someone may want to clarify that a little bit. I'll take you back to the STOPs website. If you go to the research, I'm not sure it doesn't look like it's been uploaded, but there's quite a lot of papers that we've published just recently that show about how to diagnose inflammation, and also the fact that inflammation is something that predicts a poor outcome. So the relevance of inflammation, based on our data, is very strong. So we haven't gone in and assessed inflammation. So it gets a little bit complicated, but we haven't gone in and assessed inflammation through blood serum tests, for example, treated them with STOPs and then reassessed them. We haven't done that, but we've done quite a lot of work around inflammation, about how to diagnose it, and also the relevance of inflammation on back pain. And it's highly relevant. So I'd certainly encourage people to think about inflammation. In terms of the structure of the disc, it's the only way you can evaluate. Again, that's a sort of a complex question in terms of how STOPs changes the structure of the disc, and the relevance of the structure of the disc as well. Like, you can have an annular fissure that's causing pain, and you can have an annular fissure that's not causing pain. So how relevant is the annular fissure? You determine relevance by how well the annular fissure correlates with the clinical features. If the annular fissure doesn't correlate with the clinical features, then it's not relevant. It's probably a bit of a difficult answer to explain quickly, but we haven't done any studies evaluating how the structure of the disc changes with STOPs, if that answers that question.
Okay, sir, thank you. Yeah, sir. So please go on.
I was just going to go, and I'll bring up, given that we haven't got any other questions at the moment.
Yeah.
I'll just bring up some of the algorithms to show people.
Sure.
I can find the paper. So this is part 1 of the STOPs trial. So all of the classification, assessment, diagnostic features, this is for diagnosing Z joint. You need unilateral symptoms, you need regular compression pattern on extension, and ipsilateral lateral flexion, like what I presented in the slides. You've then got protocol for the first couple of sessions as to what you're actually going to do. And then you've got the protocol for the next few sessions. This is an example of one of the algorithms that we're talking about. So let's say you go and treat them with some manual therapy. Sorry, it's not a very good picture. You go and treat them with some manual therapy, and they come back day 2 and they're better. So what treatment are you going to provide? So in that situation, you need to progress the treatment technique, progress the grade of passive treatment or the dosage of the passive treatment. If they're not better, you need to potentially look at changing your treatment techniques. So again, it's not a very clear picture, but it shows you one of the algorithms that we've got. And this is an algorithm about when they're worse. So if they come in and they're worse post-treatment, what you actually do in that situation. So there's lots of algorithms in these protocols, but they're a little bit more complicated than, say, the treatment-based classification algorithms. There's another question here. What are pain contingent graded activities in exercise? So look, this is a common challenging concept to explain. I'll just go back to the slide. So pain contingent, maybe if I'll take you up to the motor control picture, because that will help you, hopefully. Okay, so here's your motor control picture. And you can see that if you've got someone with reducible discogenic pain, let's just call it discogenic pain, or someone with disc herniation with radiculopathy, you would argue that it's helpful to try and improve their motor control, particularly to improve their muscle activation of multifidus and transversus to provide support, structural support, stiffness for the disc. Okay, so you'd start them off inside lying, doing some lower abdominal hollowing, maybe doing some multifidus activation. And if we've got enough time, I've only got 5 minutes left, but I can come back to multifidus in a tick, because that was one of the questions. So the question is, let's say they come in day 2 and they're saying, oh, those exercises you gave me are making my pain worse. I'm sore for another 3 hours after doing them. So in a time contingent rehab program, you would reassure them, you'd use hurt versus harm. You'd say the exercises are not causing you harm. Even though they're hurting a little bit, it's okay, just push through it. So that is a time contingent based approach. A pain contingent based approach would say, okay, well, these exercises are aggravating the patient for 3 hours. There's a reason for that. It's the pathology, and I need to respect that pathology. So you'd watch how they're doing their transversus. They're pulling in their lower abdomen. And what often happens is that they're pulling in greater than 20 or 30% of maximum. They're breath holding. So they're basically lying on their side and going like this. So it's like they're bearing down. They're doing a bracing type of contraction. And if you do that 4 times a day for 5 by 10 seconds, that's going to make your pain worse. So you'd identify that, you'd modify, correct the exercise, and then send them away again. So that's a pain contingent approach. You're respecting pain as opposed to sort of semi-ignoring pain, which is what a time contingent approach is. In terms of multifidus, I'll go to this picture here. The key thing about motor control when you're trying to activate these muscles is getting them in a non-weight bearing position initially that's non-painful, that's comfortable. So you can see here, and that's why side lying is such a good position, because it's comfortable for most people. You can see there's a pillow between the legs. And what you're aiming, you want to get them into neutral spine position, and then you want to palpate lumbar multifidus. So you palpate that between L3 and L5 unilaterally, just adjacent to the spinous process. So that's where lumbar multifidus is. It's all erector spinae going up through here. You can see her erector spinae here, but there's just fascia overlying multifidus here. So multifidus is the most superficial muscle. And there's a whole range of different instructions and cues that you can give to get activation of multifidus. But the most common one is just gently swell the muscle up under my fingers. And you can try and do that now. You can stick your hands on your lumbar multifidus and try and swell it up. Probably only about 20% of patients can actually do that. So there's a range of facilitation strategies that you can do to get multifidus working more effectively. And basically, The simplest one is to try and retrain a little bit of anterior pelvic tilt with lower lumbar extension. So trying to retrain getting that lower lumbar lordosis and palpating lumbar multifidus at the same time and getting some feel as to what activation of that muscle feels like. And that's a sort of a simple way of getting lumbar multifidus going. It's a little bit more complicated than that, but that's generally the best way of getting it going. And I can get probably 80 to 90% of people's multifidus going using that technique. But it's all outlined in part 3. So if you go to the website and download part 3, it's all in there. Any other questions?
So one more thing about this multifidus. How do you suggest that we assess multifidus objectively? Do we use any objective measurement to find out the activation of multifidus? Do you recommend pressure feedback?
So the PBU, the cuff, you mean the pressure biofeedback unit, the blue cuff. Look, so we work a lot with Paul Hodges and Gwen Joel, and they've pretty much moved away from the PBU, the cuff. The initial validation studies weren't the best quality studies, so it's really a clinical assessment along the lines of what you can see here in the picture. So you try and get the activation happening inside lying, and you look at what their posture's like, because that gives you a clue about if they don't have a lower lumbar lordosis, it's likely that multifidus is underactive. And you do the clinical assessment inside lying or standing or 4-point kneeling. And if they can't get that activation with all of your facilitation, then the muscle's not functioning properly. Look, like a lot of things in physiotherapy, our measurement properties, like we don't have perfect measures. You know, PAVMs, doing central PAs in the lumbar spine, not too bad for identifying painful spots. But in terms of being able to detect motion, you know, not particularly reliable. You know, straight leg raise, PIVMs, even active movement tests have got variable reliability and validity. So, you know, it's an imperfect world with regards to measurement, and it's basically just it's the clinical measure that we use.
Okay.
And ultimately, one of the best ways of determining whether what you're doing is relevant or not is assessing them and providing a little bit of treatment and then reassessing them. And if there's a change, well, then that tells you that it's relevant. It doesn't matter whether it's reliable or valid or not. If it's changing their symptoms, that's proof enough that it's helpful.
Yeah, it's correct. Thank you for answering that.
Thank you, Dr. Ford, for a very informative presentation. Hope to hear more from you soon. Have a good evening.
Thanks, Rashid. Thanks, Kundan.
Thank you very much, sir. We have almost 300 participants who is attending us live. I hope everyone had a very wonderful session and very informative sessions. And it's our pleasure to host you, sir. And we'll be looking forward in future to host you again. Okay, I thank all the attendees and the participants who have joined us. Okay, and please excuse me if some of your question we couldn't take because there was so many questions. Okay, but we will be getting back to you soon through our YouTube channel. Thank you very much, sir. Thank you for being here.
Thank you. Thanks for having me. Bye-bye.
Bye-bye, sir. Thank you.